Hello, this is Dr. Oviedo. Today we are going to review a few patient scenarios with vasculitis. The first case is giant cell temporal arteritis. At this power, you can see multiple cross sections of an artery. I want to take a closer look at this one right here. At this power, you can see there has been significant intimal proliferation. All this area here I'm going over with my cursor is intimal proliferation. You can see there is only a very small slit-like lumen left right here. I'm sure you can imagine this patient would have significant symptoms from the poor perfusion in the vascular territory of this artery. This patient had a headache that likely correlated with this affected temporal artery. You can see there are giant cells attacking the elastic lamina here, here, and here. In addition, there's significant chronic inflammation here and here. Let's take a closer look at the giant cell inflammation. Here you can see a giant cell here, here, and here. These giant cells are attacking the elastic lamina. This cell right here has multiple nuclei along with a significant amount of cytoplasm. That is the appearance of a giant cell. In giant cell temporal arteritis, the inflammation is triggered by an immune response against vessel wall antigens. In addition to these tissue studies, you can also do blood studies. Approximately 2/3 of patients will have anti-endothelial and anti-smooth muscle cell antibodies. Case 1 is, of course, giant cell temporal arteritis. Let's go on to our next case. Case 2 is Takayasu arteritis. This is an MR angiogram. You can see the aortic arch down here. In addition, this is the brachiocephalic artery, the common carotid artery, and the left subclavian artery. If you look at the origin of the brachiocephalic trunk right here, you can see that it is significantly narrowed. This, of course, would correspond to the patient's right arm pain and the lack of right radial pulse. Let's go on to the histology. These are multiple fragments of artery. You can see on the top section there is significant intimal proliferation right here. This, of course, would correspond to the narrow area seen on the MR angiogram. Let's take a closer look. In this area right here, you can see multiple giant cells. This giant cell up here even has a small fragment of elastic lamina in its cytoplasm. These giant cells are, of course, chewing up the elastic lamina. Case 2 is, of course, Takayasu arteritis. Please note the histology of Takayasu arteritis is similar to giant cell temporal arteritis. They simply affect different blood vessels. Let's go on to our next case. Case 3 is Polyarteritis Nodosa. This particular patient scenario is in the setting of chronic hepatitis B. This is a skin punch biopsy. You can see the epidermis up here at the top. Down here are some sweat glands right here. The pathology is, of course, down here. Let's take a closer look. This artery has an obvious bright orange-pink material right here, which is known as fibrinoid necrosis. You can also see marked inflammation in the blood vessel. This inflammation is composed of histiocytes, lymphocytes, and neutrophils. These inflammatory cells are reacting to the immune complex deposition resulting from this patient's chronic hepatitis B. This type of marked inflammation can, of course, cause thrombosis. This lesion correlates with the patient's skin nodules. This is, of course, Polyarteritis Nodosa. This particular clinical scenario was chronic hepatitis B, but you can see Polyarteritis Nodosa in other clinical scenarios. Let's go on to our last case. Case 4 is Wegener granulomatosis, which is the same thing as granulomatosis with polyangiitis. You can see this is, of course, a lung biopsy. The pleural surface is up here. This central area obviously is the lesion. Let's take a look at this part right here. At this power, you can see this area to the left is necrosis. There is no nuclear staining. That's how I know it's necrosis. In addition, there's a giant cell right here and right here. There is also an epithelioid histiocyte right here. If you look around, you will see more epithelioid histiocytes. Here on the right, there are lymphocytes. This is, of course, a necrotizing granuloma. You can see necrotizing granulomas in both infectious and non-infectious pathologic processes. I want to take a closer look at this blood vessel right here. This lesion right here is a granuloma. Let's take a closer look. At this power, you can see the appearance of the epithelioid histiocytes pretty well. There is an epithelioid histiocyte right here and right here. This is a large cluster of epithelioid histiocytes, so we call it a granuloma. This is a granuloma in the wall of a blood vessel. This is, of course, Wegener granulomatosis, which is also known as granulomatosis with polyangiitis. This inflammation is triggered by a T-cell mediated hypersensitivity reaction to inhaled microbial or other environmental antigens. You will remember this can also affect the upper airways. You can also do diagnostic laboratory studies. Approximately 95% of patients with Wegener granulomatosis will be positive for PR3 ANCA. Let's go on to our summary slides. Case 1 is giant cell temporal arteritis. Here is our slide. Here is a mid-power where you can see the significant intimal proliferation. I've outlined the original lumen in blue. Here on the right, you can see the granulomatous inflammation against the elastic lamina. The elastic lamina is fragmented. And down here, I've also shown lymphocytic inflammation. The inflammation in giant cell temporal arteritis is triggered by immune response against vessel wall antigens. Approximately 2/3 of patients will have anti-endothelial and anti-smooth muscle cell antibodies. Case 2 is Takayasu arteritis, which is also known as pulseless disease because it can be difficult to find a patient's pulse in the arteries that are affected. Here we have an MR angiogram which demonstrates the very narrow origin of the brachiocephalic trunk. Here on the right, I've shown the histology with giant cell inflammation against the elastic lamina and lymphocytes. The histology is similar to giant cell temporal arteritis, but this of course involves different blood vessels. Case 3 is Polyarteritis Nodosa in the setting of chronic hepatitis B. Here is our slide. Here you can see the fibrinoid necrosis and the transmural inflammation of the arterial wall. This inflammation is triggered by immune complex deposition resulting from chronic hepatitis B in this clinical scenario. Case 4 is Wegener granulomatosis, which is the same as granulomatosis with polyangiitis. Here is our slide. On high power, you can see this is the necrosis, and here are the giant cells. In Wegener granulomatosis, the inflammation is triggered by T-cell mediated hypersensitivity reaction to inhaled microbial or other environmental antigens. You will recall this also affects the upper airway. Approximately 95% of patients will be positive for PR3 ANCA. Okay, I hope you've enjoyed reviewing these few vasculitis cases.